Good morning, dear friends, and I would like to thank Dr. Chitra for inviting me to this course. So we'll look at how topography guided treatments can fix abnormal eyes post Lasik, or it can be used even for treating normal virgin corneas. Dr. Chitra has already covered its use in keratoconus. I am a consultant for Carl Zeiss Meditech. So topo-guided treatments are basically based on the shape of the cornea, and the treatment is based on data which is obtained from a topographer, and the basic aim is to regularize the shape of the cornea. And the platforms available are the Alcon Allegretto EX500, the Nidec system with CATZ, the MEL 80 and MEL 90 from Zeiss with the CRS master, that is a customized refractive surgery master, the Schwind ORK cam, Bosch & Lomb Technolast. So these are all systems which are capable of doing TopoLink treatment. The data is basically obtained from a Placido device, which gives you more of the curvature data, and Schlemflug devices are used basically for screening. We all know that the higher order aberrations are denoted by Zernike polynomials, and these are taken into consideration while designing the treatment. So if you look at the Zernike polynomials, the influence on visual acuity decreases with rising angular frequency, and at the same time a bigger radial order has a higher influence than a smaller one. So the bigger radial order actually in some systems can be eliminated to save tissue, like in the Schwind ORK cam. And ideally it is better to do an abrometry which measures the deviation from the ideal wavefront. The ideal wavefront error is 0, and this you can have an idea as to generally the blurriness in the media. The corneal wavefront specifically measures the deviation from an ideal wavefront based on a model eye, which is manufacturer dependent. The topography, the Schlemflug topography basically is used for keratoconus screening, and if there is any keratoconus, then you may either postpone the treatment or do a cross-linking. We'll not go into that as it's already covered. So how do you decide? Now you have various platforms. You have a wavefront optimized treatment, you have a topography linked treatment, you have a ocular wavefront guided treatment. So you have three options. So how do you decide when to do which? There's a decision tree. Basically you look at the cornea and ocular wavefronts. It's ideal to do both a cornea and ocular wavefront, and if you see that it is less than 25 diopters equivalent, then you can go ahead with just a abrasion free or optimized treatment, which is an aspheric treatment. If the cornea and ocular wavefront is less than 0.5 diopters and best corrected vision is better than 20/20, again if there are no complaints of night vision, then you can just go in for an optimized treatment. If there is any complaints of night vision, then again you will have to look at the difference between the corneal and ocular wavefront, and if the corneal wavefront is more, then you go in for a corneal wavefront treatment. And if the ocular wavefront aberrations are more, then you can look at the age and of the patient and any lenticular changes. If no age, if younger age group and no lenticular changes, then you can go in for an ocular wavefront. Otherwise, you will have to do either a no treatment, or you can go in for an IOL for this patient, because lenticular changes also can give rise to change in the ocular wavefront. So this is how you decide. If you look at the profiles, basically the difference between the aberration-free treatment, the corneal wavefront treatment, and the ocular wavefront treatment is that in the aberration-free treatment, the higher order aberrations which are already there are preserved, but you just have an aspheric ablation profile, and then you make a compensation for the aberrations induced by the flap and by the laser and the biomechanical effect. Whereas in the corneal wavefront and the ocular wavefront, you correct the higher order aberrations. If you look at the Q value again in the abrasion-free treatment, Q value is dependent on the correction of the spherical equivalent. In a corneal wavefront, you can actually aim for a particular Q value, for example minus 0.25, and in an ocular wavefront the change of Q value is dependent on the spherical equivalent and also the correction of the higher order aberrations, especially the Z4 and Z6, Z8. And spherical aberrations, again, existing spherical aberrations are preserved in an aberration-free treatment, whereas a corneal wavefront treatment, basically you target 0 for the spherical aberrations Z4 and Z6 with a model with a Q value of around, attaining a Q value of around minus 0.25, and whereas ocular wavefront treatment, basically the overall the ocular wavefront is targeted at 0. And then in a higher order aberrations, again with aberration-free treatment, you preserve all the existing higher order aberrations. You only optimize the treatment for correction of the asphericity and the biomechanics and the flap induced and laser induced aberrations. Whereas a corneal wavefront, you target all coefficients aberrations close to 0 for given model eye based on a Q value. And ocular wavefront, again you target 0 for all the higher order aberrations. So this is the difference between the three. This we already spoke about. So if you look at the literature is quite conducive for topo-guided customized treatment, and especially it has a lot of therapeutic benefits for treatment of irregular corneas, even ectatic corneas now. And recently topo-guided treatments are being used even on normal corneas. So if you look at the literature here, this was a publication from PGI Chandigarh, which said that topo-guided treatment provided better contrast sensitivity, lower induction of higher order aberrations, and smaller amount of tissue ablation even on virgin corneas. Another publication using the NIDEC says that it gave better night vision compared to conventional LASIK. So topo-guided treatments are being used even for virgin eyes, and you have the Contoura now from Alcon. Just one example of this was a case who had already undergone LASIK, male 24 years ago, came after 3 months with blurring of vision. His best corrected vision, he had a mixed astigmatism, and best corrected vision was 612 in the right eye. Left eye, the best corrected vision, he had a cylinder with improving to 6/9 parts. And this is his topography. You can see that there is some amount of irregularity on the pentacam, and then after the treatment you can see this is the difference. But if you look at the Atlas, we use the Atlas for the treatment, which is a Placido based system, and you can see this pre-op it is quite irregular, and then post-op it's much more regular. And we did just a topo smoothing, which is basically treating the irregularity of the cornea without any correction of the refractive error. And this is the left eye. You can see post-op it's much better. And this is the CRS master, which gives you the ablation pattern in the right eye and left eye. You can see that the ablation is quite irregular. This is basically to take care of the irregularity in the cornea. And post-op, this patient had a residual refractive error minus 0.25 with -1, improving to 6/6 in the right eye. Left eye, he had a small cylinder, improving to 6/7.5. And the maximum allowed for a topo smooth is 50 microns. And it is not a good idea to combine the refractive correction along with the topo smooth, because you just want to improve the best corrected vision and the quality of vision and night vision. So these are a few of the take home points. Thank you very much for your attention.